Welcome to the November 2017 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the November issues of the journal, as well as commentaries by Dr. Craig J. Della Valle on the article entitled Effective Obesity on Pain and Functional Recovery Following Total Knee Arthroplasty, and Dr. James G. Wright on the article entitled Serum Fructosamine, a simple and inexpensive test for assessing preoperative glycemic control. Be sure to check out this month's Current Concepts Review article, Support for Safer Opioid Prescribing Practices, a catalog of published use after orthopedic surgery by Francis Lobecchio and colleagues. The authors point out that the opioid epidemic places enormous social, ethical, and legal pressure on orthopedic prescribers to balance postoperative pain relief with responsible prescribing practices. A catalog of the type and average number of narcotic pills used by patients recovering from various orthopedic surgeries may serve as a starting point for safe opioid prescribing strategies. In addition, prescriber education and guidelines that depersonalize discussions about the maximum strength and number of pills that can be provided may reduce overprescribing. In this issue, JBJS.org presents a new image quiz, a 35-year-old man with a limp. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Effective Obesity on Pain and Functional Recovery Following Total Knee Arthroplasty by Dr. Jamie E. Collins and Associates. Investigation performed at Brigham and Women's Hospital, Boston, Massachusetts. While obesity may be a risk factor for complications following total knee arthroplasty, data remains sparse on the impact of the degree of obesity on patient-reported outcomes following this procedure. The author's objective was to determine the extent to which obesity level affects the trajectory of recovery, as well as patient-reported pain, function, and satisfaction with surgery following total knee arthroplasty. The authors followed a cohort of patients who underwent total knee arthroplasty at one of 4 medical centers. Patients were 40 years of age or older with a primary diagnosis of osteoarthritis. The authors stratified patients into 5 groups according to the World Health Organization Classification of Body Mass Index, BMI. They assessed the association between BMI group and pain and function over the time intervals of 0 to 3, 3 to 6, and 6 to 24 months using a piecewise linear model. The authors also assessed the association between BMI group and patient-reported outcomes at 24 months. Multivariable models adjusted for age, sex, race, diabetes, musculoskeletal functional limitations index, pain medication use, and study site. Of the 633 participants included in the author's analysis, 19% were normal weight, 32% were overweight, 27% were Class 1 obese, 12% were Class 2 obese, and 9% were Class 3 obese. Study participants with a higher BMI had worse preoperative Western Ontario and McMaster University's Osteoarthritis Index pain and function scores, and had greater improvement from baseline to 3 months. The mean change in pain and function from 3 to 6 and from 6 to 24 months was similar across all BMI groups. At 24 months, participants in all BMI groups had similar levels of pain, function, and satisfaction. Conclusions. Because of the differential trajectory of recovery in the first 3 months following total knee arthroplasty, the participants in the higher BMI groups were able to attain absolute pain and function scores similar to those in the non-obese and Class 1 obese groups. These data can help surgeons discuss expectations of pain relief and functional improvement with total knee arthroplasty candidates with higher BMI. Next, you'll hear a commentary by Dr. Craig J. Della Valle on the article entitled Effective Obesity on Pain and Functional Recovery Following Total Knee Arthroplasty.
This is Dr. Craig Della Valle from Rush University Medical Center in Chicago, providing commentary for the November 2017 JBJS podcast. I'll be providing commentary on the article entitled Effective Obesity on Pain and Function Recovery Following Total Knee Arthroplasty. The title of my commentary is Body Mass Index and Outcomes of Total Knee Arthroplasty, Insights for Counseling Patients. Obesity may be the most common comorbidity that I see as an orthopedic surgeon specializing in hip and knee arthroplasty. The obesity epidemic has made surgeons acutely aware of the implications of this comorbidity, and there is a substantial amount of literature devoted to the risk of complications among this patient population. Data suggests that the risk of complications is higher for those with obesity, with the risk increasing for those with a body mass index of greater than 30, with an even greater risk for those with a BMI of greater than 40, and higher still as the patient's BMI surpasses 50. While it is almost universally agreed upon that the risks of procedures such as total knee arthroplasty are higher among obese patients, the benefits of these procedures are less well understood for this patient population. One of our main charges as surgeons is to present patients with realistic expectations for recovery, as fulfillment of expectations strongly correlates with patient satisfaction, and to help them understand the risks and benefits of any proposed intervention. The work by Collins et al. Helps us in this regard by providing insight into the effect of obesity on functional recovery following total knee arthroplasty. Specifically, their study suggests that not only do obese patients have outcomes that are similar to those of patients of normal weight, but they actually had an accelerated recovery in the first 3 months postoperatively compared with patients of normal weight. Obese patients started worse off than their normal weight counterparts, but quickly caught up, having similar functional outcomes at 3 months and throughout the first 2 years. While this is very practical information for all of us to know, one of the weaknesses of this study was that the investigators grouped together all of the patients who had a BMI of greater than 40, and this subset was only 9% of their sample. Many of us encounter a large number of patients with a BMI of greater than 40, and this study unfortunately provides us with little insight into the supermorbidly obese patient with a BMI of greater than 50. In this subset of patients, we know that the risks are very high, but we are still left unsure about the benefits of total knee arthroplasty. One other factor that readers should be mindful of is that patients in this analysis came from randomized controlled trials performed for other reasons. While we all believe in the power of studies conducted using this methodology, my own experience suggests that patients who are willing to participate in a randomized trial are just a bit different from your average patient. While I have no real data to support my perception, I would suggest that patients who consent to these types of studies are those who are eager to please and possibly more optimistic, and hence their outcomes may be, on average, better than those of the general population of patients, many of whom will not consent to such a study design. The authors of this study are to be certainly congratulated on tackling a difficult and important question. By helping us better understand the functional outcomes of total knee arthroplasty in the obese patient, I know that I will be able to better counsel patients not only on the risks but also the benefits of total knee arthroplasty if they are obese.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Comparison of Treatment Outcomes of Arthrodesis and 2 Generations of Ankle Replacement Implants by Marissa R. Benich and Associates. Investigation performed at the Harborview Medical Center, University of Washington, Seattle, and VA Puget Sound Healthcare System, Seattle, Washington. The authors analyzed self-reported outcomes in a prospective cohort of patients treated with ankle arthrodesis or total ankle replacement TAR during a time of transition from older to newer generation TAR implants. The authors performed a prospective cohort study comparing outcomes in 273 consecutive patients treated for ankle arthritis with arthrodesis or TAR between 2005 and 2011. Adult patients with end-stage ankle arthritis who were able to walk and willing and able to respond to surveys were included in the study. Patients were excluded when they had another lower limb problem that might affect walking. At baseline and at 6, 12, 24, and 36-month follow-up visits, participants completed a pain score, a musculoskeletal function assessment, MFA, and a short-form 36 SF36 survey. There was significant mean improvement in most outcomes after surgery, regardless of procedure. In general, the greatest improvement occurred during the first 6 months of follow-up. Linear mixed effects regression, adjusted for differences at baseline in age, body mass index, and surgery type, showed that at 6 months the scores were improved by a mean and standard error of 12.6 plus or minus 0.7 on the MFA, 22.0 plus or minus 1.4 on the SF36 physical functioning PF scale, 32.4 plus or minus 1.6 on the SF-36 bodily pain scale, and 4.0 plus or minus 0.2 on the pain rating scale. The mean improvements in the MFA and SF-36 PF scores over the 3-year follow-up period were significantly better after the TARs than after the Arthrodesis, with differences between the two groups of 3.6 plus or minus 1.6 and 7.5 plus or minus 2.9 respectively. The differences between the two groups were slightly greater when only the newer TAR devices were compared with the Arthrodesis. Conclusions. Patients reported improved comfort and function after both surgical treatments. The average improvement in the MFA and SF-36 PF scores was better after TAR than after Arthrodesis, particularly when the TAR had been done with later generation implants. Younger patients had greater functional improvements than older patients. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Serum Fructosamine, a simple and inexpensive test for assessing preoperative glycemic control by Dr. Noam Shohat and Associates. Investigation performed at the Rothman Institute at Thomas Jefferson University, Philadelphia, Pennsylvania. Although the medical community acknowledges the importance of preoperative glycemic control, the literature is inconclusive and the proper metric for assessment of glycemic control remains unclear. Serum fructosamine reflects the mean glycemic control in a shorter time period compared with glycated hemoglobin, HbA1c. The author's aim was to examine its role in predicting adverse outcomes following total joint arthroplasty. Between 2012 and 2013, the authors screened all patients undergoing total joint arthroplasty preoperatively using serum HbA1c, fructosamine, and blood glucose levels. On the basis of the recommendations of the American Diabetes Association, 7% was chosen as the cutoff for HbA1c being indicative of poor glycemic control. This threshold correlated with a fructosamine level of 292 micromoles per liter. All patients were followed and total joint arthroplasty complications were evaluated. The authors were particularly interested in retrieving details on surgical site infection. Patients with fructosamine levels of 292 micromoles per liter or greater were compared with those with fructosamine levels of less than 292 micromoles per liter. Complications were evaluated in a univariate analysis, followed by a stepwise logistic regression analysis. A total of 829 patients undergoing primary total joint arthroplasty were included in the present study. There were 119 patients with a history of diabetes and 308 patients with HbA1c levels in the pre-diabetic range. Overall, 51 patients had fructosamine levels of 292 micromoles per liter or greater. 20 patients had a fructosamine level of 292 micromoles per liter or greater, but did not have an HbA1c level of greater than or equal to 7%. Patients with fructosamine levels of 292 micromoles per liter or greater had a significantly higher risk for deep infection, readmission, and reoperation. In the current study with the given sample size, HbA1c levels of greater than or equal to 7% fail to show any significant correlation with deep infection, readmission, or reoperation. Conclusions. Serum fructosamine is a simple and inexpensive test that appears to be a good predictor of adverse outcomes in patients with known diabetes and those with unrecognized diabetes or hyperglycemia. The author's findings suggest that fructosamine can serve as an alternative to HbA1c in the setting of preoperative glycemic assessment. Next, you'll hear a commentary by Dr. James G. Wright on the article entitled Serum Fructosamine, a simple and inexpensive test for assessing preoperative glycemic control.
This is Dr. James G. Wright providing commentary for the November 2017 JBJS podcast. I will be providing commentary on the article entitled Serum Fructosamine, a simple and inexpensive test for assessing preoperative glycemic control. And the title of my commentary is A Cheap, Simple Test That Predicts Complications. What's not to like? In thinking about this article, surgeons provide treatments for patients that on balance provide more benefit than harm. Total hip and knee arthroplasty are prototypical orthopedic procedures that aim to reduce pain and disability and improve quality of life. However, with any surgical procedure, no matter how well performed, comes a certain frequency of complications. Although thankfully rare, For those individuals with complications, the potential benefits of surgical procedures are often not realized, and for some patients, they may even be worse than prior to the surgical procedure. Surgeons have investigated and identified subgroups of patients who may not have the average benefit of hip and knee arthroplasty or may be at increased risk of complications. This prognostic information provides, at minimum, more realistic expectations for those patients, and in some cases may shift the balance away from recommending a surgical procedure. Prognostic information is used in shared decision-making to help patients to judge whether the potential benefits outweigh the risks of an intervention. In thinking about prognostic factors, they can be subdivided as either modifiable or non-modifiable. Patient characteristics typically fall into the category of non-modifiable factors. However, other factors such as obesity, smoking, and even some comorbid diseases are potentially modifiable. Diabetes is a common comorbid disease for patients undergoing joint arthroplasty that is associated with an increased risk of complications. Patients with diabetes with poor glycemic control are a subgroup of patients who appear to be at an even increased further risk. Now, some of the complications, such as myocardial infarction following joint arthroplasty, are probably due to the chronic ravages of diabetes, such as the vascular disease. However, poor glycemic control may plausibly be causative and potentially modifiable risk factor for other complications, such as infection. So the challenge for surgeons is to accurately classify patients at risk of complications. Although diabetes is a known risk factor for complications, determining adequate glycemic control in the standard fashion using glycolated hemoglobin A1C, has not been shown to be consistently associated with adverse outcomes. In this article, Shohat et al. Report that fructosamine is an inexpensive test that was strongly related to complications following hip and knee arthroplasty. Furthermore, fructosamine is associated with glycemic control in the weeks just prior to the test and appears to be responsive to changes in glycemic control. And this responsiveness is important because glycemic control in the weeks, rather than the months before the procedure, may even be more relevant to the risk of complications. And if substantiated in other studies, this report is a major advance in prognostically classifying patients prior to joint arthroplasty. So, there are several caveats to consider when evaluating the relevance of this research to current practice. First, the results do need to be substantiated in other studies and other patient populations. Second, the sample size was just a bit too small to conclude that hemoglobin A1C does not have any prognostic value and have some role in classifying patients prior to joint arthroplasty. Third, future studies need to clearly define what constitutes a normal or abnormal fructosamine level. And finally, this study does not answer the vital question of whether bringing the fructosamine levels into the lower range reduces the rate of complications. And further studies will need to determine if improved glycemic control in patients with high fructosamine leads to lower complication rates. So in conclusion, this is an important study for clinical practice. Although preliminary, this is an inexpensive test that should become part of the preoperative evaluation of patients prior to joint arthroplasty.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Pain Relief After Operative Treatment of an Extremity Fracture, a Non-Inferiority Randomized Controlled Trial by Dr. Gies T.T. Helmerhorst and Associates. Investigation performed at the Academic Medical Center, University of Amsterdam, Amsterdam, the Netherlands. Opioid pain medication is frequently given to patients recovering from a surgical procedure for an extremity fracture in spite of evidence that acetaminophen may be adequate. The aim of this study was to determine whether prescription of Step 1 pain medication, acetaminophen, is non-inferior to Step 2 pain medication, acetaminophen and tramadol, after operative treatment of an extremity fracture. 52 patients with a single extremity fracture were randomized from July 2012 to March 2015 in this 2-week follow-up, non-inferiority trial in a Level 1 trauma center in the Netherlands. Patients were randomly assigned to receive Step 1 or Step 2 medication in standard doses on an as-needed basis on discharge. Intention to treat and per protocol analyses were conducted. The primary outcome was self-reported satisfaction with pain relief measured on an 11-point ordinal scale. The hypothesis being tested was formulated before the collection of data. The mean differences between the groups were reported for intention to treat and per protocol analyses. A total of 52 patients with equal baseline characteristics were analyzed in this study. The Step 1 group consisted of 27 subjects, and the Step 2 group consisted of 25 subjects. The mean satisfaction with pain management was 8.3 for Step 1 and 8.5 for Step 2 medications. This mean difference of 0.2 point did not exceed the non-inferiority margin of 2.0 points, indicating that Step 1 was non-inferior to Step 2. A similar result was found in the per-protocol analysis. Conclusions. This study offers evidence to suggest that prescription of acetaminophen is not inferior compared with acetaminophen and tramadol in patients who underwent operative treatment for an extremity fracture. Given that tramadol has more side effects and is potentially habit-forming, acetaminophen should be considered the mainstay for pain relief in patients recovering from extremity fracture surgical procedures. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.